All right, so Dr. Keith, I know you have prepared a didactic for us. I wanted to give you the, I guess, opportunity if you wanted to advance your own slides, but I also have it on my end if you prefer me to do that for you as well.
I'm fine either way. Why don't you go ahead and do it? Because sometimes I struggle.
Absolutely, I got you. All right,
Thank
just let me
you.
know when you'd like me to go to the next slide.
Sure. All right. So thank you for inviting me to talk about this today. I'm happy to be here. So today I'm going to be discussing addressing the roles and needs of caregivers. And anyone is welcome at any time to jump in with questions, comments, thoughts, any of that. I always like things to be discussion based, so please do not be shy to do that. Next slide, please. So more specifically in terms of what I'm going to be talking about, as a broad outline. So there was a Caregiving in the US report released in 2020 based on data collected in 2019. And I'm going to be overviewing a subset of that data because I thought it was interesting and important and fairly thorough in terms of giving us an idea of who is providing care or who are caregivers in the United States, hours they spend, the main illnesses that require them to be caregivers, their perceived level of choice, self-reported health and stress, sources of report, use of resources, etc. So just kind of a broad overview of what some of that looks like in the US based on more recent data. Then I'm going to talk a little bit about assessment of caregivers in terms of domains that we want to think about and various options for tools to use. I'm going to move on to talking about more complex topics to consider, including kind of complex relational factors. And then I'll talk just briefly about some resources that I came across that might be available in West Virginia. Next slide, please. So why is this important? Dementia impacts the whole family, of course, not just the person with the disease. So caregivers are a very integral part of this. And so I think that it's important to discuss addressing their needs and roles and all of the complex factors that kind of play into this disease process. So just kind of as a background and as why this might be important, this really is a disease that affects the whole family, sometimes more so than other disease processes. Next slide, please. So in terms of this Caregiving in the US report, so as I said, this was released based on information gathered through surveys in the year 2019. And they actually do this every few years to assess change in terms of what caregiving looks like in the US. So they used survey data and asked individuals that if at any time in the last 12 months has anyone in your household provided unpaid care to a relative or friend 18 years or older to help them take care of themselves. This may include helping with personal needs or household chores. It may be managing a person's finances, arranging for outside services, or visiting regularly to see how they are doing. This adult may not live with you. So it's very broad here, but just kind of addressing broadly what caregiving looks like in the US, not specific to memory disorders, although we will talk more about that specifically, but just kind of broadly, what does caregiving look like in the US, and then seeking to include the following core areas, including kind of financial impact, access to resources, strain, who's caregiving and what the demographics look like, et cetera, et cetera. And I chose to present some of this data because I thought that it covered a lot of interesting points that I maybe didn't quite have at the forefront of my mind, even though this is gathered just based on a very small subset of the population. It's about 1,300 people. So some of these statistics may differ depending on who you're sampling, of course, and may not be entirely reflective of the entire US or of our population here in West Virginia. But they bring up a lot of important caregiving factors that might be influential and important to think about. So I thought it was interesting to read about. So I'm going to present some various aspects of it. All right, next slide, please. So according to the CDC, every year more than 16 million Americans provide more than 17 billion hours of unpaid care for family and friends with Alzheimer's disease and related dementias. And I came across actually a lot of different numbers depending on who or what source you looked at in terms of how many Americans are providing this care. But the take-home message really is that there are a lot of people providing unpaid care for various adults in the US, especially pertaining to Alzheimer's and other types of dementia. But it's unclear exactly how many. So according to the CDC, in terms of demographics of who is providing care or acting as caregivers, 2/3 were women, 1/3 were 65 or older, and 1/4 are considered to be part of this sandwich generation. So individuals who are both caring for someone who is elderly, as well as caring for children under the age of 18, which puts people in an especially difficult situation. Based on the Caregiving in the US report, you can see this graph here that kind of outlines what they sampled in terms of proportions of caregivers in every age group. And you can see that the highest proportion of caregivers fell within the range of 50 to 64. But there were quite a few in the range of 18 to 34, which kind of surprised me, about 1/4 there as well. All right, next slide, please. So as I said, this report kind of covers broad caregivers for a variety of purposes. And so this kind of gets at what people are caring for, what the main problem or illness is that requires care recipients to need a caregiver. And as you can see, the top issues reported were actually related to things like old age, mobility issues, and Alzheimer's or dementia. So this is a more common thing in terms of why people might need caregiving and support, and makes up a good portion of the group being sampled. All right, next slide, please. This was an interesting concept that I haven't really thought too much about, but caregivers' perception of choice. And so one thing that they asked is, do you feel you have a choice in taking on this responsibility for caring for whoever you're caring for? And more than half felt that they did not have a choice, 53%. Women more commonly reported to not feel like they had a choice, as well as individuals who were Generation X, which, if you can remember from the last few slides, do make up a good proportion of those who are providing care. So people in kind of that middle age group, as well as those who lived in more rural areas, were more likely to report not feeling that they had much of a choice. And I wonder if this is due to kind of access to resources, lack of access to resources, lack of access to transportation, people living further apart from each other and more isolation, and just not as many other options. Those caring for their spouse or parent were also more likely to report that they didn't feel they had a choice. And those who were caring for their loved one for a longer time. So the more time went on, the more likely they were to report that they do not feel like they have a choice in whether or not to act as a caregiver. All right, next slide, please. So the take home here is that individuals are spending a lot of hours acting as caregivers. Based on this graph here, so asking how many hours they spend in the average week helping their care recipient, 32% spent 21 and above hours, which you can think of as a part-time job. And the average hours of care was 23.7. And it's important to keep in mind that many of these people, particularly Generation X and those middle-aged and younger caregivers, still have a job that they are required to go to make ends meet. And in this sample, more than half reported that they were working while caregiving, and many were working full-time or close to full-time. And so doing this work on top of the job that they are already doing places additional restraints. Those who were African American, Hispanic, or in rural areas tended to report spending more hours caregiving. All right, next slide, please. So this here asks about how caregivers would rate their own health, just kind of broadly. How would you describe your own health? And 21% would rate their health as fair or poor. And this was actually up from or relative to 2015. So more caregivers were rating their health as fair or poor relative to the last time that they did this sample. Additionally, 23% reported that their caregiving demands was making their health status worse. And they noted that by comparison, that the same self-rated health measures, when the same self-rated health measures were used, the general US population has not seen a comparable decline over the past 5 years. That this is probably more specific to caregivers. In terms of who is at risk, they noted a significant decline in younger caregivers, especially millennials, although they did point out that broadly, millennials are experiencing poorer health earlier on than they did 5 years ago in that particular group. So more research might be needed there. But in terms of why, or another potential reason why younger caregivers might be at greater risk, is they may be more likely to have other demands such as work or being a part of this kind of sandwich generation, et cetera. So I think it would make sense that they might be at a greater risk for having difficulties with their health associated with caregiving. In addition, other people who were considered to be at risk for rating their health as poor or fair were those without any additional help in their caregiving, caregivers who lived with the care recipient. It's possible that their demands were greater if they were living with them. And again, we kind of reach this point of women and minority caregivers being at higher risk to shoulder a lot of that burden. And then caregivers with lower education were also mentioned as more likely to be reporting poor health issues. And I wonder about the influence of low SES and access to healthcare and a variety of other reasons that could also play into that particular one. Caregivers who were reporting better health, not terribly surprising, were those who were white, higher educated, higher income, and felt that they had more of a choice. All right, next slide, please. So this asks more about caregiver stress. So with the last slide, we talked more about broadly caregiver health. This was how they rated the emotional stress of caregiving. Specifically, they asked, how emotionally stressful would you say that caring for your blank is or was for you? And about 36% reported a fairly high level of emotional stress related to this. And they identified some risk factors related to this for those who might be more likely to report this higher level of stress. And the risk factors that they identified were feeling alone, and then again, coming back to this lack of choice or feeling a lack of choice. And women and minority groups, again, you might notice that these are common themes here in terms of the risk factors or individuals who are more at risk to report some of these more challenging things. Those in the ages 18 to 64, so again, you have millennials and Gen X, providing care more than a year, so those who were providing care for longer periods of time might feel that emotional stress stronger. Those who are caring for a relative, and that's compared to those who are not caring for a relative. And then, which makes sense, more hours of care. So the more time they're spending caring for the loved one, then the more emotional stress they may be reporting. So just some things to think about, many of which are fairly intuitive, but good to point out nonetheless. All right, next slide, please. I think it's also important to think about the potential financial impacts on caregivers. This is not something that's frequently talked about, but within this particular sample, nearly half endorsed at least one of these financial stressors as a result of caregiving, and 34% endorsed 2 or more financial impacts as a result of caregiving. And some examples of these are no longer saving, taking on debt, using up your own personal short-term savings, not paying your bills and having to borrow money from family or friends. So a lot of the financial impacts here can contribute to stress and burden. All right, next slide, please. This one here gets at which topics caregivers in this particular sample felt like they needed more help with or information about. So they asked, which of the following topics do you feel you need or needed more help or information? Select all that apply. And as you can see, the kind of top things that caregivers reported needing more information or help with were keeping the health or the caregiving recipient safe at home. So safety issues was a big one. Managing emotional or physical stress, and managing the recipient's paperwork and eligibility for services. And I think that these are important things because they're topics that as healthcare providers, we can be of help with in terms of addressing. And these are things that people seem to need more information and help with. And so we certainly have a role here. All right, next slide, please. So sources of help. They ask, where do or did you go for help or information about caring for your care recipient? And interestingly, the most commonly endorsed source of information or help that people reported were doctors and healthcare professionals. So again, we play a very important role in this. People more commonly come to us for help than other sources. And so it's important that we meet these needs and address these needs properly. Because more concerningly, when they were asked if a doctor, nurse, or social worker have asked about what you need or needed to help care for your care recipient, only 29% answered yes. And then even more concerningly, when they were asked, had a doctor, nurse, or social worker asked you about what you need or needed to care for yourself, only 13% answered yes. So kind of reflecting on this, I feel like I do a lot of talking about what caregivers need, join a support group, take care of yourself, do this, do that, here are all your options. But do I really take the time to ask what they feel that they specifically need in their unique circumstances to help care for both their care recipient and for themselves? I don't know. I think I could probably do a better job at that, at asking what their specific needs are. And maybe they haven't had a chance to think about it yet, but I think kind of asking that question might promote them to think about it. So that was something that I was kind of reflecting on a little bit as I was reading this. There were also several groups of caregivers who reported significant declines in having these conversations with care providers that I did want to point out. And these were people who were lower income, those who had a high school diploma or less, and rural caregivers all had a decline in reporting having spoken with healthcare professionals about that. And if you think about our population, we see a lot of that. And so keeping in mind that we see a population that may not be getting their needs met and being mindful of that. All right, next slide, please. So use of services, they assess kind of who uses respite services and who thinks that respite services might be of benefit. Of those sampled, only 14% used respite services, but nearly 40% reported that this would be helpful. And this was actually an increase relative to 2015. They also kind of looked at other support services such as transportation and things like that. And interestingly, they found that those caring for someone with a memory problem specifically were more likely to say that respite services would be helpful relative to those caring for individuals with other problems. They also kind of got into policy proposals and use of technology and things like that, but I won't get into that for the sake of time here. All right, next slide here. They also asked individuals whether or how much they agree or disagree with their sense of meaning, or whether they're achieving a sense of purpose from their caregiving. And they found that about half were given a sense of purpose. through the process of caregiving. They found that minority individuals were more likely to report this sense of purpose, and I wonder if this is related to kind of more cultural expectations to care for one's family or community. Those who had a choice or felt that they had a choice were more likely to report this sense of purpose. And those caring for a non-parent or non-spouse were, which was kind of interesting to me, more apt to report this sense of purpose. But I also think it's important that while this can be helpful, that a sense of purpose can still also be accompanied by burden and stress and a lot of more challenging emotions, and that they're really not mutually exclusive. All right, next slide, please. So incorporating some of that information and data with what we already know, here are some things that I think about when I think about assessing caregivers. So in terms of their medical and psychiatric status, some caregivers have their own complex medical problems going on that I think it's important to think about. Maybe they have limited mobility. Maybe they have their own kind of anxiety and depression that's now been exacerbated by being in this caregiving situation. And other medical issues that they have. They might be having their own memory issues, which could cause some problems in their ability to act as a caregiver. And so thinking about all of these things. Sources of social support. So do they have children, siblings, other family members? Do these family members reside close by? How accessible are they? What are their relationships like with them? Do they feel they're a part of a greater community? In West Virginia, a lot of people are highly involved in church communities. And so keeping in mind kind of that involvement and how that might impact them. Knowledge gaps, both about the disease process and kind of what they're dealing with, and different safety issues and behavioral problems that might arise, as well as kind of other complex issues in caregiving pertaining to planning for the future, legal issues, and other things that are important to be mindful of. What do they know? What do they need more information on? Areas of strength and resilience are also important to be mindful of. So what strengths do they have that they might be able to capitalize on? How much resilience do they see themselves as having? Sources of burden, and again, kind of making this as specific to the patient as possible, but some possible areas here might be hours spent, financial strain, whether they feel they have a sense of choice, how isolated they are, and other things that might be specific to their own circumstances. And then, of course, both their knowledge of resources and their access to resources. And I know that this is a particular challenge here in West Virginia and in many rural areas in terms of what's available and also how accessible it might be. All right, next slide, please. I wanted to take a minute to touch on these complex relational factors because caregiving can be accompanied by many changes in roles and relationships. And these changes in roles can affect both the patient and the caregiver. And this might include taking on new roles. So the caregiver might have to take on things that they were not used to doing. Maybe they've taken on cooking, maybe they've taken on managing the finances. And on the flip side, patients might feel a lack of self-efficacy in losing some of these roles or taking on roles that they're not used to taking on. So there's just kind of this change in dynamic and role that can evolve as things progress. I think it's also too important to think about communication as being key to any sort of relationship. And with many dementia processes, ability to communicate needs decreases as cognition declines, and that this can significantly impact relationships as someone has a harder time communicating their thoughts, their feelings, their needs. As things progress, they may not be able to communicate when they're in pain, when they're hungry, and even their most basic needs, and that can provide a lot of challenges. Emotional and physical intimacy is another important one. Early in the disease process, There may be a reduced interest in sex, or at the opposite end of the spectrum, there might be kind of a disinhibited perseveration on it, and kind of dealing with issues of intimacy and changing relationships, particularly in spousal relationships, can present a lot of challenges and be very complex. As things progress to a point where someone's loved one is unable to recognize them, that can cause significant distress as well, and impact relationships and be kind of a challenge. And then there are just a lot of different factors that impact individuals based on their historic relationship that they might have with the person that they're caregiving for. For instance, I saw a patient recently who talked to me about how she had acted as a caregiver for her mother for a handful of years up until her mother passed. And she told me that her mother had actually looked the other way when she was a child, as she had been sexually abused, and that she time and time again had gone to her mother and told her mother this, and her mother had completely written her off growing up. And that then caring for her mother up into her death was associated with a lot of very complex emotions and feelings, and brought up a lot from the past for her, and actually resulted in an exacerbation in her PTSD symptoms, and was a catalyst for her starting therapy. And so it kind of opened a can of worms there related to her own childhood and some difficulties that she had had with abuse and neglect and other things. On the other side of things, I saw a patient who had talked about having a mother who was very harsh and critical growing up, didn't have a great relationship, but as her mother actually ended up aging, declining, getting dementia, she became very kind, very soft, very different, and that it was actually a very healing experience caring for her mother and being able to experience this different side of her, even though she was cognitively declining. She said that she felt she was able to develop a much better relationship with her, and it was somewhat healing. So thinking about all of these complex relational factors that might impact someone's experience of caregiving. All right, next slide, please. So there can be this sense of ambiguous loss with caregiving, because they can be living in somewhat of a paradox with someone, or like a loved one, who may be physically present, but psychologically absent. So they may feel married but not married because their spouse is still alive, but it doesn't really feel like it's their spouse anymore, and their relationship may have changed so much that they no longer recognize it. They may feel like they've lost a parent. Their parent is still alive, but they're caring for their parent and in more of a parental role. So in some ways, they may feel like they've lost their parent. So it can be helpful to accept that this paradox does exist, and that someone we love can be both present and absent at the same time. So I kind of like this quote. It says, "It's a paradox. Something is lost, but something is not lost." So I started to look for things that were still part of my mom. My mom still has a sense of humor, and I can still share a laugh with her. She still has an emotional part of her, so I zero in on the emotion of the event because it's on a level where she gets it. She may forget my name, but she knows who I am. So kind of focusing on what still is there, and focusing on the emotionality of things, even though a lot has changed and it may feel like parts of them are no longer there. And acknowledging a lot of these complex feelings. And it's okay to also grieve while acknowledging that there are still parts where you might find joy. Okay, next slide, please. So from a practical standpoint, in terms of assessing caregivers, there are a lot of different screening measures that have the potential to be used. Within our multidisciplinary memory clinic, we use the Zarit Burden Scale, as well as the PHQ-9, GAD-7, Resilience Scale, and a variety of other measures looking at how caregivers are doing, their level of stress and burden, and other aspects of their lives. There's also something called a caregiver self-assessment questionnaire, regardless of what's given, as long as you're getting a good sense of how they're doing in various aspects. And talking to them, I think, can be invaluable as well. But screening measures can also be important and add to that. All right, next slide, please. I also think that multidisciplinary care is particularly important from a caregiver standpoint. So the needs of individuals with dementia can be very extensive and can be very complex. And this, I think, benefits significantly from having individuals from multiple disciplines weigh in and provide care as a member of a team. And that this helps broaden the focus to all aspects of care, including pharmacological and non-pharmacological approaches, and extending the care to include family members, caregivers, and all other individuals who might be involved. Finally, a goal of this might be to connect patients with resources and supports that they might need. All right, next slide, please. So I did a little bit of searching in terms of resources in West Virginia. I keep meaning to dig deeper into each of these because I know that it's great that they exist, but I have a feeling it might be more complicated than it might initially appear in terms of getting people hooked up with services. But some of the ones that I came across that sounded promising, at least, are, of course, I always put in a plug for the Alzheimer's Association, things like the 24-hour helpline, groups, seminars, hooking people up with additional resources, I think is a really, really excellent source. So I nearly always talk about the Alzheimer's Association. In terms of looking for other things that might be available, I went online to the West Virginia Bureau of Senior Services, and that was a pretty good hub to find some other organizations and resources that also exist. And some of the ones that I came across were things like the Lighthouse program, which is designed to assist those who have functional needs in their homes, but whose income or assets disqualify them for Medicaid services. So for people who don't meet criteria for Medicaid services, they can sometimes, I don't know what all of the inclusion or exclusion criteria are, but there might be services available to them through this Lighthouse program. There's also the FAIR program, which is available in every county of West Virginia and offers relief to family members and caregivers, as well as kind of one-on-one attention and individualized activities. And this is an income-based fee for this. There was something called the Life Initiative as well, that's provided by the Older Americans Act. And then, of course, there are Medicaid programs. So in terms of figuring out what particular services someone qualifies for, I certainly need more help with that, but there are some options, hopefully, that they're available to people who meet criteria for them. Next slide, please. All right, I think that's all I've got. I found this fun little wheel that kind of talks about various aspects of caregiving and where someone might be feeling that day. And it's okay regardless of how someone's feeling, whether it's a really difficult day or a positive day or somewhere in between. I think it's important to kind of acknowledge where you're at and when you might need a little bit of extra help. Questions, comments?
Thank you so much, Dr. Keith. That's such an important topic, and you always do such a wonderful job presenting. But
thank you.
That quote was so powerful about the paradox and everything. But thank you. And as always, I'll be attaching the PowerPoint in the recap email, so everyone will have access to those resources and your slides as well. Did anyone have any questions or even comments for Dr. Keith? Dr. Salido, I noticed you unmuted there.
Oh, yeah. You're quick. Yeah, thank you. Thanks for this chance to ask the question. Dr. Keith, that was a great presentation. I learned so much. Very informative, a lot of takeaways. I have a two-pronged question. I don't know if this is a fair or an appropriate question for this forum, but has there been, I was just thinking during the presentation in terms of caregiving, has there been a definition as to what caregiving is actually entails, meaning is it quantified or qualified in terms of what caregiving is defined as? Is it the number of hours or the type of care that's being given to patients in terms of ADLs, IADLs? Because there could be some family members who are just living with their, with their sons or daughters. So that's not really considered caregiving if they're just living with them. So I'm just curious if caregiving has been qualified or quantified in terms of definition. And the reason I'm asking this sort of quantification or a more concrete definition is because I'm hearing a lot of buzz about CMS being lobbied for benefits or, like Medicare Advantage, Medicare, in terms of benefits for caregivers, sort of like, transportation or like these other ancillary benefits that Medicare could provide to members. And I'm hearing some buzz that, they're sort of lobbying for caregivers to be part of the benefits under Medicare, aside from respite. So I'm just curious if there's a concrete definition for caregiving and if you've heard anything about CMS covering for caregiving as a benefit. Thank you.
Sure, that's a great question. I don't know much about CMS. In terms of the definition of a caregiver, it depends on who you ask. I mean, different studies may define it differently. Different organizations might provide services to individuals based on certain criteria. In terms of the data that I presented from that report of caregiving in the US, they defined it as any time in the last 12 months has anyone in your household provided unpaid care to a relative or friend 18 years or older, so an adult, and that this may include helping with personal needs or household chores. It may be managing a person's finances, arranging for outside services, or visiting regularly to see how they are doing. So that they defined it very broadly. Anyone who helps another person, an adult person, with their needs, and this may or may not include living with them. But different studies look at different kind of subsets of caregivers, and I'm sure organizations define caregivers differently based on who they are targeting for their services. So I think it depends. Does anyone else have thoughts on that?
I was just going to add a quick comment, independent of the definition in terms of whether CMS may reimburse for some of these services. There's an aspect of it that does make sense, because when you look at outcomes for patients with dementias, how the caregiver is doing certainly influences it. It influences whether or not they're admitted to the hospital, for example. So a study we did here, I'm going to say almost 30 years ago, I thought it was a really great study, but it's never been cited, I think. I mean, it just compared people who were inpatient versus outpatient and got a dementia workup. And there was really no difference between the patients in terms of their symptoms, the severity, their disease, or anything like that. It was all having to do with how the caregivers are. And there's a lot of data since then that really kind of points to that. And so targeting caregivers for interventions is not just good for their own health and well-being, but it also has an impact on the quality of life and the utilization of medical services for these patients who have these degenerative conditions. So there is some element, I think, that would support aspects of that in terms of the outcome.
Yeah, this is Amy from the Alzheimer's Association. I would second that. I work with the health system in Michigan, Henry Ford, and they have a caregiver program within their memory clinic there. I think we received some specific funding that we can have an embedded social worker on site within Henry Ford. And what happens is, as the clinician is meeting with the patient, the social worker is meeting with the caregiver, working on education, support, community resources, all kind of going along with what Dr. Hout said. It's so important to keep them healthy, keep their stress level down, because they are an important piece of the care for this patient. They, I believe, do the Zaret burden interview. So they are doing it post, so when the caregiver is coming in, they're giving them the different education interventions, and then doing it post to see if that's improved their stress level. But yeah, it's such an important part of this. And Dr. Keith, thank you so much for plugging the Alzheimer's Association. And Teresa can't make it on the call today, but she sits within West Virginia, and I think looking ahead, I think it might be to the benefit of the staff there to meet with Teresa and myself, just to brainstorm all of the resources that are out there to make sure that we're identifying any potential gaps Teresa, I know, has a wealth of resources as well that she's using. So just making sure that we're kind of comparing notes and filling in maybe where there are some gaps.
That would be great.
Thank you all so much. Meredith, I noticed you had unmuted as well. Did you have a question or comment?
No. I did have a question. So we're working on a program to support our Alzheimer's and dementia patients within Aetna. And so we're really focusing in on the caregiver. And one of our issues is that a lot of our members do not have the caregiver designated yet. So we can't engage because of that. In any of your research or, any of, prior discussions that maybe we haven't been on, how has that been overcome? Like what are the thoughts around getting access to the caregiver? That first education would be around becoming that designate within our system so we can start engaging and providing support. But any thoughts there to kind of break that barrier? And is there a provider role here that maybe we could help to educate and influence the provider? Any thoughts there?
When you say you can't access the caregiver, do you mean they're not properly appointed as power of
Correct.
attorney, or like from a legal standpoint?
Correct. From a legal standpoint. So when we're looking at programs where our health plan could help better support the member and their caregiver, we can't, and they have dementia, we can't get access to that caregiver yet because they haven't been appointed.
Yeah, that's tricky.
So this is Mark. I would say two things. We kind of deal with that, Meredith, in two ways. In a formal way, having sat in on multiple appointments with Dr. Navia, for example, now, I mean, he says right off the bat as a geriatrician, if you are over this age, you should have a medical power of attorney. What can we do to help you with that today if you don't have that? And that follows up in the feedback that we have following a workup, which is we are recommending that this happen. Here are the steps that we can do to help you with that, for example. So we do that kind of formally in there to broach that topic. Informally, we begin that by always inviting to the initial workup somebody other than the patient to join them. So we informally get a sense of who the primary contact person is going to be for this individual because they come to them with that appointment. And if nobody comes with them, then that is a specific question we follow up with them on. Even if they're very, very mild or may not even be showing dementia at this point, but very early MCI, we're always thinking about that in the future. So we do formal and informal ways to try to kind of get this connected to address these issues that you're talking about.
That's helpful. And how do you, one thing we're trying to be very sensitive about is our members even acknowledging they have dementia. And so we don't want to start pushing paperwork on them inappropriately. How do you navigate, how do you approach that conversation?
Well, I'll just say very quickly, it really depends upon their level of insight and awareness of this. And if they have like zero insight into the fact that they have cognitive changes, I'm not going to get close to that, but I'm going to plant a seed with them that maybe they don't realize some of these changes so that we can approach it down the line. Whereas if they have very good insight, then we'll just address it directly. So it's really a continuum based upon their insight and our perceived, what our perception is, I think, of their relationship with their primary caregiver and how that may interact with that. I don't know, Dr. Keith, what do you think?
Yeah, I agree with that. I think it completely depends on the situation and their level of insight and their relationship with their caregiver and all of the above, and how I approach it might be differently. And in terms of how hard to push, I mean, I may start with saying, kind of planting those seeds, like you can't remember what you can't remember. And depending on how forcefully they push back, then I might address it differently. So I agree, but it's a delicate situation.
Very helpful. Thank you.
Any other questions, comments, or thoughts anyone wanted to share with the group? All right, well, if there are any, oh, Elizabeth, yes.
I just wanted to say thank you so much for that presentation. In the paradox, like we helped my grandmother as a caregiver in the past, and you know, you have pieces of them that show up, and she thought my dad's name was John. It's definitely not John. Or she wanted me to be little still, like she'd argue, and she was very strong, so she'd argue, she stayed with us, and she'd say, no, my Elizabeth's little. So I think, yeah, but just trying to hold on to those little pieces of someone and you get to see the glimpses that's a beautiful paradox. And this is such an important topic. I do appreciate you speaking upon it.
Thank you.
Absolutely. You said it perfectly, Elizabeth. I 100% second that. You really covered it so nicely. If there are any questions after the fact, as always, feel free to reach out to myself or Elizabeth, and we'll make sure to have them addressed for you all. If there are no further questions, I do only have one announcement, and that is our next session will be on June 1st, which I can't believe it's already even May. And Dr. Ward will be discussing cognition and comorbidities. So just keep an eye out for that reminder. Big shout out to Dr. Keith. Thank you again for preparing that awesome didactic, and we'll see you guys next time. Thank you.
Thank you.
Thank you.